Right, everyone. This is Jane Holliday Goldman from the National Center for Child Traumatic Stress. And I'm going to just talk for a couple of minutes and introduce our presenters, but we really hope to use most of the time today to have a discussion. So we'd love to hear, where you are in the process and what questions you have about specific tools or tools that you're developing. If you're not familiar with the National Traumatic Stress Network, or the National Child Traumatic Stress Network, or the NCTSN, we are a collection of about 79 currently funded and over 100 formerly funded sites around the country, funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to collaboratively work on issues related to child trauma. You can check out a lot of our resources if you haven't already on nctsn.org, and we'll probably refer to a few of those today. I'm at the National Center for Child Traumatic Stress, which is the site that coordinates the work that we all do together. We are co-located at UCLA and at Duke University. My colleague at the National Center at UCLA is Dr. Isaiah Pickens, and we are both really thrilled to be working with NCGA-FCJ on this project, and that we really hope you'll think of us as a resource for training, workforce development, interventions, information for parents and caregivers, really anything around creating trauma-informed systems. Today I'm going to help to lead the first of a series of discussions on screening and assessment for child trauma and child traumatic stress. But again, we just want you to know that we're available throughout the process, and NCJ-FCJ can help coordinate any of that technical assistance or consulting or training that you might be interested in. So my role at the National Center is the Director of the Service Systems Program, and in that role I work with sites and with communities to create trauma-informed systems. That covers a really wide range of activities, including identifying and implementing culturally appropriate and evidence-based screening, assessment, and treatments for child trauma, making resources available about trauma to children and families and providers, strengthening the resilience and protective factors of children and families, addressing parent and caregiver trauma, emphasizing the continuity of care and collaboration across systems, and developing and maintaining an environment of care for staff that addresses and minimizes and treats secondary trauma and increases staff resilience. So today we're going to focus on that one very important piece, screening. My knowledge in the area tends to be broad, so I dialed a friend, or I dialed 3 friends, and invited some fellow members of the network to join me so that we can have a deeper conversation. They know a lot more about it than I do, but I'm pretty confident that between us we should come up with some pretty good answers to whatever questions you might have about screening for child trauma. So I'm going to introduce my colleagues. I know you received most of the bios ahead of time, but I wanted to give you a little information about their expertise so you can be thinking of questions that you might want to ask them. And one morning I have another presentation I have to do at noon Pacific, so I'm going to drop off at that time, but I believe my colleagues are still going to be able to be on. So Dr. Lisa Conradi is the Director of Clinical Operations at the Chadwick Center for Children and Families at Rady Children's Hospital in San Diego. In that role, she oversees all the clinical programs at the Chadwick Center. She's authored and co-authored a variety of publications on trauma screening and assessment practices, creating trauma-informed systems, and presented nationally on innovative practices designed to improve the service delivery system for children who've experienced trauma. Lisa is also the longtime co-chair of our NCTSN collaborative group that works on trauma screening and assessment in child welfare. And she's been working, I believe, with a couple of federal agencies to kind of comb through everything we know about screening for trauma and child welfare to develop some guidelines on that topic. Dr. Cassie Kissel is a research associate professor at Northwestern University, Feinberg School of Medicine, and the principal investigator and director of the SAMHSA-funded Center for Child Trauma Assessment and Service Planning, which is part of the NCTSN. Amongst her other vast experience, she has a lot of experience in supporting the development of trauma-informed systems and conducting child trauma research and evaluation with a focus on trauma assessment, complex trauma, dissociation, and resiliency. She is the primary developer of the trauma version of the Child and Adolescent Needs and Strengths. That's the CANS instrument, which I believe many of you have looked at as you've been exploring different instruments to use in this process. And then finally, Dr. Ernestine Briggs-King, in one of the many hats that she wears, is my colleague at the National Center, although she works on the East Coast at our Duke University office, where she's the director of our Data and Evaluation Program. She's also the director of the Trauma Research and Evaluation Program at the Center for Child and Family Health, which is also in Durham, North Carolina. As part of her current work, she's involved in the implementation and evaluation of evidence-based practices aimed at reducing the impacts associated with maltreatment and child traumatic stress. She has extensive experience with the development, implementation, evaluation, and dissemination of interventions with urban minority youth at risk for maltreatment, trauma, delinquency, and sexual risk-taking behaviors. And she has expertise in the area of culture, gender, and systemic issues. She's also the co-chair of a group that we have in the network that coordinates all of the various efforts in our network around trauma screening and assessment across systems. So I felt that this cross-system work would be particularly important for you all as you're developing and implementing statewide screening tools. So I am going to turn it over we do have some slides. As I said, we weren't exactly sure what your questions might be, but we thought we'd kind of go over a little bit of information and then open it up. So we hope you'll be thinking of questions along the way. Lisa or Cassie, am I going to start with you?
So just a quick sort of side note for technical difficulties. I don't know, Jane or Ernestine, if you've been seeing your email. Lisa Conradi, who actually primarily pulled the slides together, she and I have done this, and Ernestine as well in other settings, but Lisa has not been able to get on the call. I don't know if she's having some technical difficulties, so I had suggested maybe somebody from NCJ, FCJ could perhaps help her walk through it. Apparently it's not letting her install Flash on her computer. So unfortunately, I don't think that, Lisa, are you on yet? No. Okay. So
send her an email to join by phone, and that should help at least for her participation if she can't join by the webinar.
Oh, okay. Oh, you can do that?
Yes.
Okay, great. Great. And do you have her email address to do so?
Yes, I believe this is Carrie. I do.
Okay. Yeah, you know what? I'll just before we get started, because Ernestine and I can kind of go back and forth, and hopefully Lisa will get on. I will, Carrie, just loop you into this exchange, and
okay. Yep,
okay.
I had looped her into it too, Cassie.
Okay, great. Thanks.
Thank you.
Okay, sounds good. All right. So Ernestine, do you want me to start off, and then we can kind of go back and forth?
That sounds like a great plan.
Okay, sounds good. So, and I think we both have presenter rights here, so let me see if I can go ahead and advance this slide. So one of the things that we have done a lot of work on, all three of us collectively, is really thinking through not only some of the differences between screening and assessment, but also thinking through some of the key questions to be asking yourselves as you consider implementing new tools within your system. And some of the early work that we did around this, I know in collaboration with Jane and others from the National Center, when we started to think about these issues primarily starting off within child welfare systems, is really taking a few steps back. And one of the things that we have heard throughout the network and in other systems, and by the network I mean our National Child Traumatic Stress Network, is that there still is some confusion around definitions and what we mean by screening and assessment. So we thought that it might make sense to just be on the same page around definitions in terms of screening and assessment as we started off. So what do we really mean when we're talking about screening, assessment, as well as evaluation, as some of these terms are often used interchangeably, and how do you know when it's appropriate to do one over the other?
Hi, Cassie, this is Lisa.
Yeah.
Can you hear
me?
Oh, great.
Okay,
they just turned on the microphone, so I'm here.
Oh, terrific. So, Lisa, do you want me to just take these next couple, and then you can give it back to you?
Go for it, yeah.
And Ernestine? Okay. Okay, and obviously, Lisa, Ernestine, please feel free to chime in. So I'll just quickly kind of go through some of what we've talked about, and we actually, I think at the end of this, we have references for you where you can read more about this. Is that right, Lisa?
Yes, we do.
Okay, so in this particular slide where we talk about the definition, we actually published a paper around this very topic in the Child Welfare Journal a few years back, so you can look into this more. But just to give you a broad sense of what we're talking about, when we talk about screening, and I know there's been a lot of discussion around screening within this group and in this conversation, we're really talking more so about this, a broad, brief questionnaire which really gives us which is administered to everyone in a particular setting. It's usually brief, easy to complete, and gives us more yes-no information. So when we think about trauma-informed screenings, for instance, as one particular topic area, we tend to think about did trauma occur? And sometimes those screeners will go into more detail around the range of trauma types. Did trauma occur, and is there an impact that this trauma has had on the particular functioning of the child or youth? And it's usually, some are longer than others, but it's usually not much more in depth than giving some brief information in those different areas. Whereas once we hear that, for instance, a child may have screened positive, so to speak, for having a history of trauma or some trauma reactions, then oftentimes that may lead to a referral for more in-depth assessment around what does that look like in the child? What kind of reactions may the child be having in response to trauma? And usually that referral happens from whatever system we may be working in. So if we're working within juvenile justice or child welfare where that screening may occur, then oftentimes that referral, depending on your system, may be to somebody in the mental health system who are trained to do more in-depth and comprehensive assessments, which often requires some training that goes along with it, and it really gives us a range of the picture of what the range of responses the child may be having across domains of functioning in different areas, the range of what their background looks like in terms of trauma experience, and usually this information is used to inform whatever treatment or services the child or family may be referred to. And it's usually more of an extensive process completed over at least a couple of visits. We have more in-depth information around assessment, but this information that we're presenting today is more targeted to screening, since I know those were some of your questions. And then finally, psychological evaluation, or referred to sometimes as psychological testing, goes into even more depth, looking often, this is completed by psychologists, gives very specific information, could be around IQ, around various types of other information, personality style, et cetera. So those are some of the differentiating factors. Lisa or Ernestine, anything else you might want to say about that?
No, I think you did good.
Yeah,
Okay.
I kind of like the analogy you guys often use, which is screening is just casting a wider net, right? And
Yeah.
catch any fish, yes or no. And then assessment might be to kind of sort it out. Did you get some snapper, some grouper? What'd you get? Did you get some shrimp in there? To really kind of figure out. And then maybe psych eval would be even going even deeper. And so kind of thinking about screening as broad, general, yes or no, big ticket items.
Yeah.
Anyone can ask those kinds of questions.
Yep.
And I think an important point to mention here as well is, we've worked a lot with child welfare systems, and I think anytime you work within a system in which the folks who by virtue of the nature of their involvement in the system are likely to have been exposed to a trauma, it begs, I think, a pretty obvious question of why would we bother screening, or does screening really capture what we need to, because a lot of our kids are going to screen in. And there's been a lot of debate about what's kind of an acceptable number of what would screen in versus not screen in terms of moving kids more towards an assessment. And I would say that part of the reason we would really advocate for screening is that just because a child experienced a traumatic event, it doesn't mean that they every child is different, every person's different, every family is different. So how a child responds to that event, the effects of that trauma, is really what we're looking for. So I know that one of the discussion points that was mentioned in kind of as a precursor to this webinar, and something folks are hoping to kind of get out of it, is this idea of screening for events versus screening for effects. And I think at least in our experience, and I certainly defer to Cassie or Ernestine to share their experience, we have just found that events aren't enough, especially when we're working with highly trauma-exposed systems. And that we are really looking more for the nuance of what they have experienced the effects of that trauma. So.
Right, and just to add to that, I would totally agree. I think that a lot of the discussion, for instance, around the relation of for instance, if you've heard about the 3 E's and SAMHSA's terminology around that with the, event, the experience, and the effects, it's important to have all 3's. And that's why when we talk about traumatic events, we often use the terminology potentially traumatic events because for some kids, they may or may not have difficulties around certain areas. They may have more resilient adaptations or competency around certain areas. And so we want to make sure that we're not just looking at the event as a sign that the child needs treatment or services, but that in fact the event is then, or a series of traumatic events is leading to some kind of reaction that may require those types of services. So maybe I'll just take the next slide here, Lisa, because I know it's just kind of a segue here. So one of the things that when we think about this larger process of screening assessment in relation to treatment or services, we hope to see this kind of, to some degree, linear process, if in fact any of our processes are fully linear, but that we have, that brief kind of, as Ernestine is saying, kind of casting a wide net to see if in fact there is a history of trauma and if that trauma is in fact having some kind of a negative impact, and then hopefully that will generate referral to more in-depth understanding of what those needs are. And I think that assessment process is really critical as well, because we really hope that once we get that more comprehensive picture of what the child's history looks like, what their particular needs are around areas of functioning, and then I would also add in, what their areas of strength are for both within the child, within the family system, within the community. What kind of supports or strengths are in place, so that we can better understand the full picture of what's happening in that child, and then target treatment or services to those needs. So I think that linkage is really key. In fact, and oftentimes that doesn't happen as fully as we would like to see, where the treatment or services are linked back or directly informed by the information from the assessment. And so, we're hoping that, in our efforts that we can support that more, that process where all those pieces are better connected. So anything more on that piece, Ernestine or Lisa?
I think you're good.
Yeah,
okay.
I think you're good. Do you want me to, I can jump
Sure.
in and take the types of screening tools?
Sounds good.
So as Cassie alluded to, in some ways we're trying to create linear processes and compartmentalize things, and you guys will find that really the nature of this work is thinking about a particular system or individual situation. But what we have done is try to do our best to kind of compartmentalize the types of screening tools that exist, but understand that there is, sometimes we hear some fluidity in this process. So there's 3 kind of real categories that we've identified. The first is a screening tool that would be completed by the child themselves. This would usually be by children at least years 8 and above. That will certainly vary depending on the tool. And they have the capacity to read and complete the questions. One of the perks of a tool like this is that you're asking the informant directly to share about their experience and the effects of their experience and their responses to their experience. So you can get that information firsthand. But that's not always feasible. And so there are also tools that are completed by the caregiver. That would be tools for younger children, usually ages 0 to 8, or it could be maybe older kids with some developmental delays, and that would be more appropriate to have a caregiver complete the screening tool. Some of the challenges with that is you might have a difficult time identifying a caregiver that would be a really good informant. In some cases the child might be in foster care or might be in a in a group home, and we might not be able to have somebody who really knows that child's experiences, but if they do, really getting that person to inform about that would be really helpful. The third category is kind of what we've termed a provider-completed tool. So there are a number of tools out there, and Cassie can speak in great expertise about the CANs, which I think would fit this category, where it isn't necessarily that you're sitting with the child or with the caregiver and asking them specific questions, but it's that you're taking the information gathered from multiple informants and multiple sources and using that to integrate and complete a tool. So this might include court reports, interview with caregiver, reviewing files, other questionnaires, behavioral observations, because we do get a lot of information about children. Well, I guess there are some kids we get a whole lot of files about their history and what they've experienced, and some kids we don't get that, but we do have some information that we can work with. So a provider-completed tool is a way to take that information and kind of distill it down to inform us in the way that we need to. Cassie or Ernestine, do you want to add anything on either any of those types of screening tools?
Sure. I mean, just with regard to, for instance, the CANs as an example that Lisa brought up that we call an information integration tool. It's also, clinician provider reported as well. And one of the things that's important to keep in mind around that, there is a training and certification process that goes along with that, such that providers that use the CANs, and you may be familiar with this, understand the importance of really using, integrating and collecting information from a range of different sources. So I've seen this since I work with a lot of different systems that use the CANs and consult to them, and some folks have the process of sitting down. Sometimes they turn the CANs into some targeted, even semi-structured interview types of questions, but we hope that it wouldn't just stop there. So some systems also use more what we would call, and I know, Lisa, you'll probably go into detail around this, more kind of standardized or established tools to factor into those decisions as well, but we also want to make sure it's used as what we call a communication tool, so you're having that outreach with other providers, other service systems the child may be in contact with. So really thinking big picture in terms of how we can consolidate all of this information into one place in a tool like this.
Great. Anything else?
I'll let you go on.
Okay. So I'll go on to the next slide, which is really about key considerations for the implementation of a trauma screening tool or process. I think this is where really the meat of the conversation will be held. And essentially, we kind of put this in here as a way for agencies or systems to really think through the kinds of tools that they might be that might be the most appropriate to implement within their given system. So there are a lot of tools out there. For one of our projects, I actually had a staff person just start doing a review, and this project, which felt like it was going to be a fairly easy and quick project for somebody who was just stepping into a role, a great way to become accustomed to the work that we do, could go on for years. And part of the reason is that there are a number of tools that have been created that have published research on them, different variances of the kind of research. Some have okay sensitivity and specificity, which is kind of what we're looking for when we talk about screening, which means does it identify the kids that it needs to and not identify the kids that it doesn't need to. So that's something that's an important consideration. But there's a lot of homegrown tools out there. And part of the reason that, and I think this was a question that came up for discussion among this group is, what are the pros and cons of developing a homegrown tool? And, I think maybe a general rule of thumb is that, the more research that is done on it, there can be more cost associated with purchasing that tool. That's not always the case. We know of some tools that we have started looking at that are free, but a lot of times folks develop their own tool because of the cost that it takes to either purchase the tool, to program it into their system, to continually use the tool, and if they purchase that tool, does it actually get everything that they want to? So folks have developed their own tools because they just found that there weren't any tools out there that did the work that they were looking for it to do. So I think, this is where the rubber meets the road in terms of this thoughtful implementation process. So we want tools that are likely going to be a little shorter. A shorter tool may not give you as much information, so you really have to weigh kind of do a cost-benefit analysis. If you want a lot of information up front because that's going to inform a lot of different pieces of your system, that might very well be a worthwhile use of time and resources to do that for you because it'll flow through the system. Other folks might just need a brief screening tool at the beginning of their system, and they know that kids are going to go on, and they're not necessarily going to track back to that. So that is definitely an important consideration, and it's tied very much with cost, like I said. Tools that are free or low cost are more likely to be sustainable, but sometimes there isn't the research on them that we'd like. So we really have to prioritize what is the most important thing for this specific system. Other considerations are the age range targeted with the instrument. So there's a lot of different age ranges. I will say that one of the areas that I think that it's a little more tricky is with very young children. So that may or may not be as relevant for this group. But if you're looking for trauma symptoms in the 0 to 3, those behaviors and those symptoms are going to look very different than they do for an older child. And most of the tools are for kids older than 3 that are trauma specific. So in super young children, we're looking more for attachment difficulties and social and emotional distress, which doesn't really map onto some of the screening tools that exist for older children. Other consideration is a method of administration, so things that can be administered maybe more quickly, or if you have the resources to provide kind of that training that Cassie referred to when talking about the CANs and with other kind of information integration tools, is that we really want our workforce, if we're going to ask them to administer a tool, to be trained on how to do it. And there's different levels of training depending on the tool. And I'll go ahead and jump to the next slide and finish this piece up. The other issue is respondent. Who do you have access to when completing the tool? Or is the child or youth kind of readily available? Is the caregiver readily available? So when you're thinking about implementation within your specific system, you're going to really want to think about who is a good respondent for the work that we're doing. Translation in available languages. We're, for example, located in San Diego. We run a clinic. Approximately 50% of our families are primarily Spanish speaking. And so for us, the use of tools that have been translated into Spanish is of primary importance. And finally, I've already talked a little bit about this, but that's empirical support. So, you really are doing kind of a cost-benefit analysis. There's, unless my colleagues might know of something, I'd love to hear about it, but I don't think there's a tool that is like the one gold standard that hits all of these boxes and checks them off for us. That's the number one question everybody asks me, like, if you could pick one tool, what would it be? And my response is, its system has to kind of figure out and prioritize what their needs are, and then kind of have a thoughtful selection process so that this isn't just kind of reading about something and deciding to go for it, but it really does have to be thoughtful. So with that, I'm going to ask my colleagues to jump in because I know there was a lot that I just talked about that they could add to.
Well, one of the questions that came up, Lisa, was how short is short?
Right.
10 items or less, but what's your thought on it?
Well, we've used a tool that is 4 questions, the Scared Short. We're having kind of mixed feelings about it because it's very much PTSD specific. And then we've put that with the Strengths and Difficulties questionnaire, which is a little bit, that's a longer tool that has more broad. Yeah. So there is a 4-question tool. We've also played a little bit with the CRIES 8, which is an 8-question tool. So pros and cons to that. I don't know. You're a screening expert, Ernestine. What do you think?
Well, I said the answer was 10 items or less is generally considered short.
Yeah.
You know, I've seen everything from a 2-item to a 10-item in that category. But again, I think hitting on some of the points that you made, like what's your priority areas for screening, who's going to be doing the screening, are there cost factors involved in it, and then really what you want to be thinking about is, are you getting meaningful information from the screening items that you're delivering?
Right.
Short is better, but if it's not getting you what you want, then you might want to take the time to expand it to make sure that you get what you want or need. So,
Absolutely.
So that's a good question, Lori.
Definitely.
Cassie, did you have any thoughts?
Yeah, I mean, I think you covered it nicely in terms of this whole process, and it is kind of a balancing act in terms of, you know, all of these different factors that come into play. And I think, you know, one of the other things, if we think about, I know we're talking more specific to trauma screening, but as I think about the assessment process, and that's more of what we're focusing on now in systems that we're collaborating with. And I think the other factor to consider is, in addition to translation as far as how you have it here in terms of true translation around languages, is thinking about how whatever tool you're using, and I think this goes for screening as well as assessment, can be translated into your practice in your given setting. So kind of thinking through some of the practical applications, which I know we're going to talk about on the next slide, how likely will it be used, and how much will it be connected to some of the existing practices that you have in place. So again, you know, just a kind of a preview of what we're going to talk a little bit more about. But yeah, these are just all the various, so it seems like it's to some degree, a complicated process, but I think we just want folks to really think about how to really keep these things in mind, and there is no one set tool that we could say is perfect for every system. It's a matter of weighing these, you know, various issues that are important.
Absolutely. Okay, so maybe I'll go on to the last slide before the resources and walk through that, and then we can kind of come back as a group and think about additional questions and make sure we've addressed everybody's kind of thoughts and questions. So the final slide, you know, prior to implementing a trauma screening practice or tool, again, we've really, you know, I know our group, as well as Cassie, as well as Ernestine and other agencies around the country, have really thought about this implementation of a screening process. And I will really be upfront that, you know, we have been funded as part of the ACYF Access to Needs-Driven Services, and it's a 5-year grant program, and we're about 3 years in. And part of that is the implementation of a trauma screening tool or process. And you know, I'll be honest in that I kind of thought the implementation of the screening was going to be the easy part, because we also have to think about mental health assessment and service array for treatment and those sorts of considerations. And I kind of thought, okay, you know, when I'm timelining the whole project out, I thought it would take about a year to implement this screening process. And what I have found is that it's so much more complex than I had originally anticipated, that, you know, really it's not about finding one tool or one process, but it's really about figuring out how to fish as your system. And one of the things that we've really seen systems do that I would venture to say is maybe kind of virtue of the need to implement is that they haven't necessarily done the most thoughtful implementation of tools, at least around, you know, I'm in the state of California, and there's been a big push for implementing screening tools here. And part of it is I think there's just this need to get it done because there's a mandate to do it, and I can completely understand that. But what we've seen has happened is that they hear about, you know, a neighbor or another system that's doing something, and they decide they're going to do it, and they kind of go full bore behind it. And then later on, they find that there are some issues or problems with that particular tool, that it didn't quite get what they wanted to get. And so a lot of our process has been really sharing that we need to slow down. We need to identify what are our priorities when we want to implement a screening tool. What are we hoping to accomplish? What do we want to get out of it? And do we have the right people at the table to think through this process? So the first thing we have listed here is we want you to pull together kind of a team that includes somebody who knows about research and psychometrics. That's one of those things, to have somebody that you can talk to who can help you think through it is incredibly important. The other thing is that, really embedding and integrating it into an existing system to maximize the efficiency of it. Broad training needs to be provided. We have found that we've been, not us, but like systems have been implementing screening tools, and the staff don't really know. They don't have the training necessary to do it properly. They don't understand kind of what is trauma and what is not trauma. So really creating a common language within your system about what are we intending to accomplish, what is trauma, how does this particular screener work, where does it fit in our larger service or continuum. The other thing is to develop a relationship with a mental health partner to ensure that screening leads to an assessment. I can't highlight this enough that screening cannot happen in a vacuum. You can't conduct a screening and then put that information in a chart and then that be done with it. You really have to use the information to inform the work that you're doing and have it connect. And one of the key ways to do that is make sure that there is a referral to mental health or referral to higher level of service embedded within your screening process. The other thing is to think thoughtfully about who are your informants for the screening or assessment tool, as I talked about before. Pilot test it. This is a really important step that I think we don't always do because we're kind of in a rush to get this out, get the process moving. But really to stop and have some staff members try the tool out with with the families that they serve. What's working about it, what's not working about it. I usually recommend that, after a system does its review of the tools, that is kind of up at the step one here, that they pick 3 or 4 that they like and they pilot test them and they kind of identify the pros and cons, because then you can see what it would really look like in practice. And we often miss that piece of it. Finally, one of the things we learned from a project we did a couple of years ago with child welfare systems is that when you start screening specifically for traumas that you don't know about come up. So we've kind of assumed that kids in juvenile justice, kids in child welfare, kind of families involved in the system, that our workers kind of knew everything that had happened to the children and that they were prepared to hear it. But when a particular worker is asking a child about all the trauma, not just the trauma that brought them to their attention, they were hearing about how tough and all the challenges that this child had faced. And we'd had reports of workers, and I know, Ernestine, you can share this as well because I know it happened with your team as well, but that they were having effects about it, and it really meant something to them. And so having a system where we address secondary trauma is incredibly important. So with that, I'll invite my colleagues to jump in to the discussion.
Cassie, you want to go first, or do you want me to?
Well, no, just the one broader comment I was going to make around this is that I think it's really key to see, as we've been saying, screening or assessment practice is truly a practice, and it's not just a standalone thing. And I think that's one of the things we've been learning over the years in doing this work is that, I'm kind of thinking about some of our colleagues, for instance, who are family partners, family members, foster parents, like our close colleague, Mandy Taylor, for instance, who reminds us of how important it is to have that family perspective in play, but really think about the folks that you're serving in some ways with these tools and have it's a part of the practice. It's a part of building that relationship, and obviously that the impact that it has on your staff and yourself is really key as well. So just thinking through, and I like these bullet points because I think they really spell out some key things to really keep in mind. I mean, it's not just whether it's a 4-question or a 10-question or a 50-question tool, it's really important to think about how you're embedding that practice and the impact that it will have on you or your staff and the families, and to really support your staff so they can do that effectively and integrate it into other areas that you're trying to improve in your system as well.
Yeah, a couple of things that I would just add on to this is just to echo and kind of give you some examples of some of these things that Lisa and Cassie have both talked to us about. So in North Carolina, one of the things that we did was we got a team together. We had some research folks on the team. We had some child welfare, juvenile justice, mental health, schools. It was a pretty diverse team. And we did a pilot, a small pilot in a couple of counties of a pilot of a screening tool that we wanted to use in North Carolina. And the pilot was going fairly well. We started to look at the data coming back. And one of the things that we didn't prepare for enough was that whole notion of addressing secondary traumatic stress. And I think because of rates of turnover, amount of exposure that our folks have on the front line, that I can't stress that enough. So, for example, one caseworker who had this pretty horrific maltreatment case tried out the tool, and she was like, really, I don't think I'll learn anything more about this family that I don't already know, given their extensive history with the department. And she began to learn about trafficking and other events that were going on in this family. Had she not done the tool, the kids would have not been, the circumstances of how they proceeded with the case and the treatment that ensued would have not gone that way. And so she is probably the biggest advocate of beginning to screen, and not just kind of abuse and neglect, but other types of traumas that the kids might be exposed to. So I think being able to do that is a really important part as y'all think about cross-system screening and becoming more trauma-informed. The other part was to create the holding and supporting environment for workers as they began to find out more and more things about their cases, and really how to really address that. For that particular worker, because she had been working with the family for almost a year. And had she known sooner, she could have done something sooner. So being able to create a space to process that and really help her kind of deal with some of her secondary traumatic stress reactions was really important. So I think kind of thinking about this is not just selecting a tool, but all the things that need to be put in place to do it well and to really kind of look at your implementation are going to be really important key ingredients as you move forward.
I don't know if there's more that we want to say on I know the last slide on resources, but I know that I'm mindful of the time too, and it does look like we used about half the time to talk, which is good, so we have about 45 minutes left for discussion. But is there anything more around this resource slide? And I know, Ernestine, you have several different resources as well, but I can just jump in here that these are, I think, some useful websites for all of you as you think about the process of identifying screening tools and assessment tools. If you want more information, the NCTSN website is obviously key, and within that we have a measures review database, which I know Ernestine can say more about, but there's been a lot of extensive work around that in terms of review of an extensive number of tools that are out there in terms of populations, ages that they're appropriate for. The other thing I would say as far as an NCTSN site that's useful is I worked very closely on the complex trauma web pages, and we have a specific web page devoted to assessment of complex trauma, and we have a grid of standardized tools that help tap into the different areas or domains of complex trauma as well. I know the California Evidence-Based Clearinghouse for Child Welfare is another really useful site that gives a lot of information on a range of assessment tools, as well as their evidence associated with it. I can speak to the CANS website. It's a website through our center where we have not only information on the CANS tools, but a lot of information related to how the CANS can be applied in more meaningful ways in practice. And actually, I think some of the resources that we have are more broadly applicable as well. We've been doing a lot of work around how you can really think about using a tool like the CANS in communication with other providers. So, types of questions that a caseworker or a clinician or a supervisor may ask to really embed the CANS in more meaningful ways into their practice. We also have several resources on, we have a tip sheet on use of the CANS with parents and youth, so ways to think about how do you translate this information back to families in a meaningful way. How do you use the CANS to really ask those questions in a more family-friendly way. We also have videos showing illustrating how you might do that. And then finally, the Child Welfare Information Gateway, which is another useful resource around screening and assessment tools. Anything more on that particular slide, Lisa or Ernestine?
And I guess the only thing I would add is that, a lot of our conversation today has been about screening, and a lot of the resources that are available, and I'm thinking specifically of like the measure review database as well as the California Evidence-Based Clearinghouse for Child Welfare, they're probably maybe a little bit more assessment tool driven because they're driven by what tools have kind of research support in many ways. I mean, the measure review database has kind of a mix of both, whereas the California Evidence-Based Clearinghouse has been refining its process to really report more on those with published research. So I guess my caution would be that these are a great place to start. There's some good information there, but it is in no way going to reflect kind of the vast amount of tools that are out there, and I'm not sure of a resource that really captures them all, just because we've had to go through a process where we tried to review, and it's been quite time consuming. So hopefully that could exist at some point, but I don't think that kind of a one central location that reviews the pros and cons of tools exists at this time, although if somebody wants to write a grant, maybe that'd be a great project to take on.
So I'm trying
to mention a couple of the other tools. We had gotten a few questions around screening for child trafficking. And so I put some specific tools that are used. We just had a meeting a couple of weeks ago where screening for trafficking was one of the things that we talked about. And through that there were really 4 tools that kind of rose to the top. So they're either in the downloads or the discussion notes, and there's also a matrix that the West Coast Trauma Clinic, I think is what it's called, that they put together that has a matrix of all of the tools used and what it's used for, how long they are, et cetera. So if you want to take a look at those and have any specific questions, then that's something I can either answer or point you to somebody who can answer.
The other thing that I would point you to is a really fabulous tool that I came across in May, and it's actually funded by NIMH. It is part of the Society for Implementation, Research, and Collaboration. And they have what is called an instrument review project. I just put the details in the chat bar. And one of the things that they were really noticing is that sometimes we recreate the wheel when there's already a good measure out there. But we may not know the name of the measure or exact details, but we might know the domain of interest. And so one of the things that you can do with this instrument review project, you'll have to register to gain access to it, but is you can put in something like, I want to know about depression, or you want to know about family engagement, or you want to know about PTSD. And what you can do is just put in some search terms, and it'll come up with all the measures that are available that assess that domain, and it'll give you some additional information about the psychometric characteristics, where you can find out more information, if it's available, some of the items from the scale. It's a really cool, comprehensive project. I think it takes together what the measures review database from the NCTSN and some of what is happening with the Gateway and the clearinghouse resources have done in the past, and just kind of made it a more searchable, doable feature. So I would definitely invite you to try that out. It is, again, put on by the Society for Implementation Research and Collaboration, a group out in Seattle. And some of you, if some of our Montana sites are out on there, there's some really good resources in Montana that are related to CERT that you guys can speak to as well.
So I think this is Crystal with the National Council. It'd be helpful to open it up for questions right now. What we're going to do, if you want to ask questions over the phone, is if you raise your hand, so at the top of the screen you'll see an icon with a little man, and if you hover over the down arrow next to that little man, it'll give you an option to raise your hand. If you raise your hand, we'll go in and unmute your phone. The chat is obviously also available. Lori, I know you said that you had some questions, so we'll go ahead and unmute you right now. If you want to get us started with some questions.
So creating your own tool?
Yes.
I guess I would ask them about that.
So we're just curious because we haven't met with Montana actually yet, and we've been working because we couldn't find one tool to look at crime victimization. And that there's kind of tools specific to different kinds of victimization, and then there's tools specific to all different kinds of trauma. But so we have been kind of working with our TA provider under the, to kind of work from other tools, pulling questions from other tools to create something that would fit our needs. And I was just curious as to your thoughts on that process, or because we haven't been able to find a tool that identifies our target population necessarily.
This is Lisa, and I guess, I certainly defer to my colleagues, but, you're not alone in that, and there's definitely been folks, different systems, kind of grappling with, they're looking at this particular issue, or they want a broader version of this issue, and it just doesn't exist. And so that really has necessitated the need to create a tool. And, that kind of comes into the priority. Like the priority is identifying the group, kind of doing the work, and trying to gather the information that you need. One of the downsides of that is you're not sure if it's going to screen in or screen out according to kind of research. And so there's, what I usually recommend when folks develop a tool is that part of that development is looking at doing an evaluation on that tool so they can really see if it's doing what they're hoping that it can do. So I'll defer to my other colleagues for more thoughts on that.
Yeah, in terms of victimization, and especially with crime, I think of the work of David Finkelhor and our colleagues in New Hampshire who's done a lot of work on that. Their tool is not brief, and so some of the sites across the network have either taken subscales or the whole tool and decided to commit to either piloting it as is or piloting with different subscales that are most relevant to what they're hoping to achieve. So in this case, you're looking at criminal victimization, and so there is a subscale that has some of those. I can't remember the exact amount of items, but that would be a good place to at least start and see what kinds of questions that that are part of that.
Can you tell us where that's from again?
Sure, I'll look it up and put a link on the chat bar.
Great, thank you.
And the only other thing that I would add to that is that I agree that when possible to pull from, if not use, but pull from established tools. But I think one of the things that we have heard, depending on the system, that for screening purposes, there's some, some folks do go ahead and create their own tool because there's not a particular tool that has precisely what you need, and especially if you want this to be a brief inquiry, it's important to make sure you're getting those questions addressed that are specific to your population. So I think that, I would totally agree with what Lisa is saying, and Ernestine as well, that when, if in fact you do end up creating a tool or even adapting a tool to really try to collect some data or, evaluate how that process is going and get some feedback on that tool as well. Are there other questions? Or I know we have several additional resources that we've posted as well, for folks who are interested, and I know we have several others too that we could share.
We're happy to unmute others' lines if you'd like us to. As an option, we can also unmute everyone's line, and then you'll just use the mute on your own phone. That'll take us a minute, so if that's what we want to do, just chat to us that you would like us to unmute everyone's line or that you'd like us to unmute your line so you can ask a question. Again, you can also raise your hand at the top of the screen to let us know that you have a question. I wanted to ask, good, there's some questions coming in. This might be a quick question. Lisa, you mentioned that you had asked staff to collect some tools, and it sounded like that was a project that took longer than you thought it might.
Mm-hmm.
Was there the name of that project that you could share with our group?
We created a grid that I'd be happy to share. I just need to get my colleagues' permission to do it because I know we put a lot of time into it. Eventually we were hoping to do a thorough review and write a paper on it. We've just found that that's not high on our priority list as the grant is working, so we may not get to the paper, but I certainly have the grid that I can share with you that has some of those initial findings.
That'd be great. Thank you.
Mm-hmm.
We are going through and unmuting everyone, so if you don't want to talk, please be sure to mute your own line using the function on your phone. But I did see Ernestine is typing, the National Crime Victimization Survey developed by David Finkelhor at University of New Hampshire is a resource. A lot of his work is definitely a resource to us. And as Ernestine is typing these in, Carrie's entering them over into the discussion notes. So if you're not able to click on them right away, go over to that box on the right-hand side, and you'll be able to access those links.
Yeah, the Bureau of Justice has some of the parts of the survey available. So the link that I sent you includes access to those so you can see some of the questions.
Great, thanks. Lori, I saw that you were typing. If you have a question from your group, go ahead and ask. If we get more than one person talking at a time, we can figure that out. So don't be afraid to ask a question or chime in. That goes for everybody.
Hey guys, this is Bethany. Can you hear me?
Yes, we can.
I just wanted to mention that in the past, one of our projects at OVC used, they were interested in doing a screening at their school to find out how many students at the school had experienced victimization and exposure to violence. And so the process that they went through, once they really liked Finkelhor's group screening tool, but they really wanted to, shrink it down, of course, and use some plainer language because they were administering it to some kids who they just wanted it to be in more understandable language. So their process was that they reached out to that group and had some conversations, and they were very accommodating and open to, having discussions and very comfortable with sharing their tool and having it be adapted. So just passing that along as an FYI.
They are an incredibly collaborative, so I just want to echo that. It's a great group of collaborators there.
It may help that they get funding from DOJ, but
they do. But sometimes we in academia are a little bit tight with our stuff, and they are not. They have been very generous, and if you have a question, they'll help you think through some of it so that, again, that you're doing that part of thinking about what's most important for you to find out and how to implement it given their years of experience with the tool. They'll also tell you some of the shortcomings of it as well, so you can kind of make informed decisions about whether you go with that tool or something else. Hey, Cassie and Lisa, there was a question about reading level for tools that far. I said third grade. Is that generally what you guys use, or do you go for fifth?
I think third grade is
fourth, third or fourth, yeah.
Yeah, third or fourth I think is a good rule.
Yeah, we just try and keep things as simple as possible, jargon-free whenever we can when we're using it, even for providers.
Yep.
You guys have lots
and when,
of questions. Go ahead.
The only thing I was going to add to that was when, in cases like the cans where, we've been given some feedback since it is, the tool itself is really more of a manual, so some folks use that as a guide to support whatever interview they're doing, that looking at the manual itself, it can be somewhat jargony or technical. So given that we have to, in some ways, follow suit with other versions of the cans, one of the things that we've done as a means to support that is we oftentimes develop a glossary that goes along with it to explain some more of those technical terms and what they mean, like dissociation or affect dysregulation or those kinds of things. And then some systems have also developed a corollary interview, as I mentioned before, to go along with it, which is in a a language that is a little more easy to understand. Because when family members see the manual, and sometimes they want to, they say, "Wait, this is way too technical for me." So, when in fact we can't fully change the language to the level that we want, we develop accompanying materials to support it.
I think Lori has a question. She had her hand raised.
Actually, someone in our group does, so I'm going to turn it over to her.
Hi, this is Haley Matthews in Virginia. This is a question that I have less about specific screening, as it's actually more related to capacity, and it gets into some of the points that were made earlier around the need to properly train folks in understanding, the merit of not only just administering a screening tool, but doing it properly. And so to kind of take that a step further, given that there are so many bright minds on the other end of the line, my question is, outside of, specifically identifying whatever screening tool makes the most sense within the context of whatever environment you're in, can anyone speak to the capacity building you all have done that really prepares the field, both on the public and the private end, to be prepared for what comes down the pike after you ask those questions? And that gets in more to what happens when you get into assessment, what happens when you get into evaluation. I think that's been a big concern that I've had personally, but I've also heard echoed by some of our other colleagues that, screening is great, but again, if you build it, they will come. And so, we don't want to overpromise and underdeliver in terms of asking even these questions and recognizing that there are issues, and then really not having the proper infrastructure, both, again, on the public and private side, to be able to respond to those needs once they're identified. Can anyone speak to that?
This is Lisa, and I can at least kick off the response by sharing a story that I think really reflects the concern that you're raising. For our project, we're working in various California counties to build screening and assessment practices for kids in child welfare. And we had started with screening, as I mentioned earlier, and that was took a little bit longer than we thought, and there were certainly some challenges with that, but we had a really fantastic county who really took this and ran with it. The challenge we ran into, and we had the same leadership for mental health and child welfare in that county, and really supportive leadership, so we had that in our pocket as well. But the challenge we ran into is that the mental health system, at least in California, isn't just as, the county mental health system doesn't just serve child welfare children. And you guys might run into this as well. So any changes that they were looking to make regarding assessment, so what happens when you identify and you refer, they needed to make so that it applied to every child who might come into their system. And so that, for us, really created a much larger conversation so that that system could be a part of the conversation and be responsive to the needs. So as you said, we were building it in the child welfare side, and they were coming, they were showing up when we were identifying the kids, and we were identifying, I think, a really, we were doing a good job of that, and we were referring, and we wanted to make sure mental health was ready, but the level that they needed to consider really was more than I think we had initially anticipated, and it's part of the learning process. But what I'll say is that there is a benefit to building it. They were coming and informing that process. So sometimes it's not always kind of the neat and clean kind of concurrent capacity building where across the system everybody rises up at the same time in order to support this intervention. It's that you're kind of, sometimes you're building the plane as you're flying it, and so one piece kind of got worked out, and we were identifying these kids, and the system responded. And so some of that is just the interaction with the system. It wasn't pretty. We're not there yet, so I don't think I have a really great answer to your question other than acknowledging that it's an issue and that everything we're doing, I think, is pushing the system forward and making them think about things that they just hadn't been able to think about prior to. So with that, I'll let Cassie and Ernestine jump in.
I mean, what I would add to it is what we've done, and we also have a lot of lessons learned through this process when we've rolled out the trauma version of the CANS as really the statewide primary assessment strategy. Is we were very careful in sequencing our initial rollout of this a couple of years ago, where we did it in what we were calling more of a learning collaborative, if you're familiar with those. It was a pretty massive scale where we did training and support for all of our caseworkers and casework supervisors in the system. And so prior to rolling out the certification training on the CANS itself, we made sure to facilitate different sessions of what we called Trauma 101, Trauma 201, so that there were at least background skills around what is trauma-informed practice and what does that mean for caseworkers. And so we did that piece and then introduced the CANS and then talked about service planning. I'd say our challenge lesson learned is that we did, based on the mandate of our director at the time, we did it statewide because he wasn't a fan of pilots, so it became a bit of a massive undertaking. But now we're at the point, fortunately, under our new administration, where we can take a few steps back and do it in the way that I think is more meaningful, and in that we are in conjunction with, since it's really hard to think about in-person training, which is literally what we tried to do with an army of folks with 3,500 plus casework staff in this process. So it was kind of mind-boggling even just thinking about the logistics of doing that. But what we're doing now is kind of thinking more about how to support the field Both, with some more trauma resources, trauma training, and having that be more virtual, but then reintroducing the cans and doing what we really think is a part of good practice in terms of the follow-up implementation support. And I think this gets to some of your question around, what do you do when you have some of these reactions? How can we support the field? So we have a team of folks who are part of our CANS implementation support team who are also trauma-informed, and so we have different mechanisms for bringing those people together. On a statewide basis, we pull together the therapists who are already using the CANS, and we have kind of these peer support groups where we talk through some of their challenges of using the tool in trauma-informed care and trauma-informed practice, and then we're going to do that kind of virtually more through webinars and conference calls and supporting the folks in the field, the casework folks who are using the CANS as well in their trauma-informed practice. So I think with what the take-home message is, with whatever we do, we don't want to have it be just a standalone tool, but really a process that is, embedding the CANS or whatever tool you may be using in trauma-informed practice and kind of working through different case examples and challenges with some of those issues that may come up.
This is Laurie. I had just kind of a follow-up. One of the things, so you're mentioning some therapists and your child welfare folks that were training together. We have been, for the past couple of months, doing regional events with folks from probably 8 or 9 different disciplines, child-serving systems, and what we're repeatedly hearing over and over again is that they want to train together using the same information, which is a challenge, but I didn't know if there had been, any of you had any experience with training all of those groups together, because that was one need that was really identified, was that everybody needed to get the same information about how to do it in order to collaborate. And I can see, for me, if we picked one system, it'd be pretty easy, but that was one of the things that they said was a disadvantage, was that they always get training only with their own folks, and they never get to train with the other people who they would be referring to.
Right. One of the things that we did in North Carolina, and Lori, where are you, by the way?
Virginia.
Okay, so we did a similar thing in Virginia, which was we did an overview of trauma, kind of like a little trauma summit, and we had everyone come together.
I'm here, Ernestine. This is Pam. I'm here.
Hey, Pam.
Hey.
So, and one of the things that we try to replicate in Virginia was this idea of training everyone about kind of like what Cassie and Lisa talked about, like this overview of trauma and overview of trauma-informed care. And then in North Carolina, one of the things that we did was we had juvenile justice, the schools, and everybody break up into what we call affinity groups and talk about facilitators and barriers. And then the next step was to bring them all together and think about how do we go across systems. So first of all, identifying what in their systems might support this or might get in the way of this going well, and figuring out what those things are first before we had a conversation about how do we do it cross systems. Pam, I don't know if you want to talk about what we did in Virginia.
If I can remember.
But it was something similar, yeah.
I do remember. Didn't we take the domains,
trauma-informed practice domains? Mm-hmm.
Yeah, and then we had people break into groups and choose one of those and how they would do that in the system.
Mm-hmm. And then we try to kind of make those groups cross-system groups so that they could talk about what struggles that they would have within their systems and what struggles would they have and expectations would they have without. So, for example, child welfare can identify the cases, but does mental health have the capacity to do the further assessment? What do you do for your advocates? What do you do for your judges? What do you do for folks in schools? And then how do you begin to work together? And I would assume that North Carolina is not alone, but we haven't figured it all out and how best to work together across systems because we can't even share data. And so, but it created an opportunity for us to select 9 counties within North Carolina to pilot some of these things in a much smaller scale and then replicate, and we're currently in the process of replicating it in a larger scale in North Carolina. But that's kind of how we went about it, at least to get the conversation going and have people thinking about it and troubleshoot and generate some solutions to some of the barriers that are out there.
And we did get a lot of that information in our cross-systems mapping events. We actually did case study where they had to map out where they would, and then we're going to draw a big map where everybody's maps are on one. And our TA providers come here in February, yeah. So, and I think that was I think everybody was kind of like, well, we get this training, even if it's just the trauma 101 piece. There are people being trained on different things,
right.
Different things, different ways, and that's one of the pieces that they don't feel like they're all receiving the same information because it's kind of, and hopefully with this project there'll be some consistency because it seems like there's different waves of funding that come through, and then there's this training, and then there's another wave of funding that comes through, and there's a whole nother training, and we're not really working off the same
But if
page.
we did it in terms of like we tried to do it when you were here before, Ernestine, was we did it, in terms of the community.
Mm-hmm.
So
right.
you could community by community and
right.
and use and have everybody there.
Right.
Mm-hmm. The other thing that when I was doing some training with South Carolina that they have done is, so for example, Lori, we wouldn't teach your JJ folks how to do TFCBT unless that was the clinicians available to do treatment with the kids in the JJ system. But one of the things that was really important was if we think about referral agents as brokers, as connectors to the different service systems, is to be thinking about a higher level of training for the brokers so that they have the language and can say, well, TFCBT is for X, Y, and Z. And this thing might be for, this other evidence-based treatment might be better because it's dealing with adolescents, or this one might be better because it's dealing with young kids and behavioral problems. And so giving them not so deep a lesson on the different evidence-based treatments or assessment and screening measures, but a higher level enough to know that, okay, this kid is screening positive on behavior problems and lots of trauma. I need to send them to a mental health clinician so that they could assess for that in a more comprehensive way, and so that they became more informed brokers or referral agents, and that has seemed to work really well, particularly among child welfare, juvenile justice, and mental health systems as they.
We have a question in the chat, and I'm going to read it because I know there are some folks who are only joining on the phone. So Monique, who's from Virginia, says, moreover, the Trauma 101 becomes a little redundant for professionals who have received extensive training and understanding of trauma-informed care. Is there any discussion about more advanced trauma training, more along the integration or any plans for certification and CEUs to become qualified professionals?
That's a good question. I know in North Carolina we've been doing more advanced training to get us beyond the 101, but we try to get everyone to do the 101.
Yeah, and that's a great question. In Illinois, we've definitely struggled with the same issue. And back to the earlier question that I think Lori posed, we have We have tried, we've had that same issue of trying to bring everyone together and trying to have that mixed group of folks, including therapists and caseworkers. And, depending on their role and their length of time in their particular role, they're going to have different backgrounds. So I think, as Ernestine is saying, kind of getting everyone on the same page, even if it's a review of information, I think is key. And then I think where we've done that more targeted work is in what we're also calling affinity groups, or our super user groups, where we bring folks together excuse me, kind of based on role to just get more in a more targeted way into practice issues. And we've utilized and adapted things that folks on this call, Lisa in particular, have been primarily involved in, like the Child Welfare Trauma Training Toolkit. We have other resources as well that we've developed and adapted as far as getting into more concrete and practical strategies. But we found that that's a tricky thing to do in a large group because everyone's at different levels. So we've tried to cater those or target those to more these smaller peer support group discussions.
And I would echo that. We've certainly run into some of the same challenges. We did a very similar model to what Ernestine described, where we did trainings where we brought different systems together, and we did them in regions around California. And on the one hand, I think that was incredibly helpful because it started to establish the common language that we really wanted, but we definitely ran into the same issue where we found that some folks had way more training than other folks, and it really kind of brought up areas and issues of discussion across systems that were conversations that they frankly needed to have. And so the follow-up for that wasn't necessarily advanced training, although we've certainly talked about the need to develop something like that, and I think that there's some work happening within the Child Welfare Trauma Training Toolkit subcommittee on more advanced training. I'm not sure where that is, so there's not a lot I can say about that, but that it's where we dive deeper with those smaller groups. So very similar to what Cassie was talking about, that you kind of do the broad training, but then there's the opportunity within a specific system to dive deeper, and that's more the advanced at this point.
We're approaching the end of our time together, so I think we have time for one more question. Don't see any hands raised or chats coming through, so Ernestine, Cassie, or Lisa, is there anything you wanted to add as closing thoughts?
I'd just like to thank everybody for the opportunity to talk with the group about these issues. It always is helpful to share and invigorate the critical thinking as we look at implementation of screening.
Right, I would agree with that, and we're always happy to support the work in various systems. And I know that Jane, who I know had to get off a little bit early, had suggested she can be a point of contact for any follow-up questions that you may have around any of the resources or tools that we've talked about today. And if there's we have plenty of resources, as we've alluded to. So if any of those would be helpful, we can also share those with Carrie or Crystal and get those out to you more broadly.
And the resources that we have within this webinar, both in the discussion notes area and the downloads, Carrie will be sending those out to our contacts. So you'll have all of those. Eventually, you'll also have a recording of this webinar for your reference. And the best way to get in touch with Jane or anyone else at NCTSN is to go through Carlene or Michelle. And they can get you connected with NCTSN as well as, of course, others in the field. If any questions come up after, which they sometimes do, please definitely get in touch with us. And I also wanted to remind everyone about the survey. That helps us make these better, and we appreciate very candid feedback on those, and that's the only way we will get better. So thank you so much for your time today, and we will talk to everyone soon.
Take care, everybody.
Thank you.
Bye-bye.